Cardiovascular, Pharmacology, Antiarrhythmics, Sodium Channel Blockers, Class 1. All right, so for the Class 1 antiarrhythmics, and essentially for all other antiarrhythmics that we're going to be covering, Class 1, 2, 3, and 4, sketchy is going to be your best friend. It breaks it down very, very easily for you to understand. Once again, I'm just going to be covering the highest yield things that I think are very, very important, but you have to watch sketchy, okay? The second thing I will say, for all of these antiarrhythmics, since this is a podcast and it's something that you're only going to be listening to, I definitely recommend opening up your book and looking at the graphs in which these antiarrhythmics are going to be showing, okay? And how they affect each of the cardiac graphs. Very important. You have to know these graphs, okay? They question you on them all the time. There's so many questions that ask you about it. You have to know the differences between these graphs. It's very important, okay? So to begin off, we have the antiarrhythmics Class 1, and these are sodium channel blockers. So Class 1 is going to be sodium channel blockers. And Class 1 is broken up into Class 1A, Class 1B, and Class 1C. Okay, so there's 3 different classes within Class 1. And the difference between them is their ability to bind to sodium channels. Okay, so that's all that it is. So Class 1C has the strongest ability to bind. Class 1A is the second strongest, and Class 1B is the weakest at binding to these sodium channels, okay? And what they do is that they will slow down or block the conduction, okay, at depolarized cells. And they overall decrease the slope of phase 0 depolarization when it comes to our cardiac cell depolarization, repolarization graph, okay? Action potential graph. So we're going to be decreasing the slope of phase 0 on our cardiac cell action potential graph. All right, very important to know. You have to know it. And so all it is just going to be tilting over that phase 0 over to the right. That's what all these Class 1s do. Now, the difference between them is how does it affect phase 3, okay? And we're going to see the difference, okay? So for Class 1A, you have quinidine, procainamide, and you have disopyramide, okay? So those are the 3 drugs you have to remember. Okay. Once again, the mechanism of action is that it has moderate sodium channel blockage because Class 1A was the medium binding strength. Okay. So it has moderate sodium channel blockage, but it also has some potassium channel blockage. And since it has some potassium channel blockage, what you're going to see is that you're going to get a longer phase 3. Okay. Because phase 3 is sodium channel or is potassium channel dominant. So if we block potassium channels somewhat in Class 1A, then we're going to have a longer decrease in our slope, okay? So you're going to see a longer phase 3. Okay, very important because, as we said, if you block sodium channels, you have a potential for an adverse effect of torsades de pointes. So that's why we see for Class 1A drugs, one of the adverse effects is torsades because of that potential potassium channel blocking effect, okay? Because it increases the QT interval. All right, next, the adverse effect for quinidine that you have to know is synchronism. They love to ask this, and I probably pronounced it wrong, but all that it is that if you see headache or tinnitus, that means that you have synchronism with quinidine, okay? They love to ask about that. Tinnitus is just the ringing in your ears. And then procainamide's adverse effect is reversible lupus-like syndrome, okay? So we now have seen 2 drugs that cause reversible lupus-like syndrome. This one is procainamide, which is a Class 1A antiarrhythmic, sodium channel blocker. And the second one that we already covered was hydralazine, okay? So keep those 2 in the back of your mind. Lastly, disopyramide is contraindicated with heart failure patients because of its effects on the heart, all right? Not as high yield, all right? Moving on to Class 1B. Class 1B, once again, is the weakest of the sodium channel blockage. And you might be asking yourself, why would we use it if it's the weakest? Well, the reason we use this is for patients that are post-myocardial infarction because it has a preferential effect on ischemic or depolarized cells, okay? So by the way, all ischemic cells, all cells that are like lacking oxygen and are about to die, they all are constantly depolarized, something that I didn't know. So Class 1B has a favorable attraction to depolarized sodium channel cells compared to 1A and 1C. So that's why it's best to use post-MI because you have so many ischemic cells. All right, so it's best post-MI. If a patient comes in and they're asking you what antiarrhythmic should you use post-MI, okay, or with ischemic tissue at all, you're going to answer Class 1B drugs. And the Class 1B drugs are lidocaine, phenytoin, and mexiletin, okay? Now, the adverse effects are just CNS stimulation or depression. Really not asked on. The only thing that they really ask about this is post-MI, okay? Next is Class 1C, okay? Class 1C is flecainide, okay, or propafenone, okay? Now, what this does is that this is the strongest sodium channel blockage, okay? Strongest sodium channel blockage that you're going to be seeing. And what we care about is its clinical usage, okay? So we're going to use this for patients that have atrial fibrillation. And I already told you the drugs that we use for atrial fibrillation to control it is going to be rhythm control, rate control, as well as anticoagulants. So we're going to be talking specifically now, class 1C is very, very helpful for rhythm control, okay? Now, you can't use class 1C drugs, however, in patients that have structural or ischemic heart disease. So opposite of class 1B, class 1C is horrible for using it on patients that have ischemic heart disease or structural abnormalities. So make sure you keep that in the back of your mind. It's contraindicated because it has pro-arrhythmic effects, especially post-myocardial infarction, post-MI. Okay, so keep that in the back of your mind. But remember, class 1C is going to be really, really helpful for your rhythm control for patients that have atrial fibrillation. All right, so overall, this is your class 1 antiarrhythmics. They are your sodium channel blockers. And since they're sodium channel blockers, that means they are going to change your slope of phase 0 because that's where mainly your action potential occurs for your sodium channels. And when they change your slope of phase 0, all they do is that they're elongating your QRS complex, okay, without elongating your QT interval, depending on which one you're using. Class 1C elongates the QRS complex, but it does not elongate the QT interval because you keep down, there really is no potassium effect, okay? So make sure you understand this. I'm going to restate this one more time. They're sodium channel blockers, okay? And so they change the slope of phase 0, and we know that phase 0 is just the action potential, right? And that action potential of the ventricles relates directly to the EKG of the QRS complex. So if we're changing phase 0 and we're decreasing that slope, right, we're making it longer, that means we're going to make the QRS complex longer, okay? If you have any questions on this, please ask me, but honestly, your best friend's going to be sketchy for these antiarrhythmics.